Professor Adam Friedman, Department Chair and Residency Program Director at GW School of Medicine and Health Sciences. From a clinical perspective, I like to think of myself kind of like a train wreck dermatologist, a complex medical dermatology. But from a research perspective, I get my hands in a lot of different things, both basic science and clinical. And for the purpose of today's discussion, I really like to look for innovative approaches to filling in gaps as it comes to access to care, as well as improving diagnostic accuracy of disease. I think, the term access, comes with a lot of different meanings. The A's of access, can relate to the most obvious in terms of physically being able to get to, in this case, a dermatologist's office or dermatology practitioner's office. This could relate to whether there are no dermatologists in your area. And that was one of the concerns and the impetus for starting a remote clinic here at GW in an area where there's no dermatology services available. But once again, that access can relate to actually having the time or the ability to get to a dermatologist's office during the hours of operations. Maybe it's related to financial access, having the means, the insurance, or even the ability to pay for a copay, or maybe it's paying for prescriptions or even over-the-counter solutions. That can also limit one's access. So I think that those are some of the obvious targets when we think of access concerns, but there certainly are other things as well as it relates to even comfort with a particular physician, access to healthcare competency, or even technology competency that can limit one's access to appropriate care. So I think there are many disparities that we can focus on and address that are affecting populations that are within, whether you call it a healthcare or technology desert. No question, areas of DC fit the bill on all those accounts. Sure. So we just recently launched a call for applications for a grant program that will fund institutions around the country to emulate what we were able to figure out and create here at GW in Washington, D.C. during the pandemic. And I think when the pandemic hit, that hammer fell and we were kind of cut off from our patients, many of us rapidly pivoted to incorporate telemedicine as part of our daily practice. For some, probably easier than others. But the waiver based on that state of emergency really opened the floodgates to enable us to care for patients regardless of licensure in certain areas, allowed for proper reimbursement for said services. And so in dermatology, being a very visual field, and telemedicine has kind of been part of what we've done for a long time, we were able to migrate very quickly over to telemedicine to maintain the level of patient turnover and patient access. But what we found early on, we actually conducted a study at GW that while patients were super excited and happy about telemedicine, it was allowing them to maintain care or even see us for the first time. A very small subset of those patients coming to see us came from certain areas of Washington, D.C., areas that we already knew had many access challenges, like Ward 7 and 8, some of the poorest areas of D.C., areas that have very limited access to healthcare. And so what I realized was that while, yes, telemedicine enabled us to maintain care for many, the access revolution with respect to telemedicine widened the disparity gap, widened the healthcare access gap for those who already had limitations getting to see a dermatologist. But now that gap was widened because the only opportunity was with telemedicine, and there may have been other access issues related to why they couldn't use that approach. So at the same time, recognizing these issues, Pfizer issued a call for applications for a quality improvement project utilizing telemedicine to address many of the issues that I and my colleagues were observing. And so that enabled us to create what we call the telehealth help desk free clinic, where we're kind of combating two issues. One is in this clinic, which we set up shop in a church in Ward 8, Temple of Praise Church, where parishioners or local residents can come in. They get educated on best practices for telemedicine, really demystify, because until you actually go through an audio-visual synchronous visit, it can seem a little overwhelming, a little scary. Like, how do I work this thing? What's the link? How do I do this? Are they going to be able to take care of me the right way? We got that a lot, when we first launched telemedicine during the pandemic. So the whole point is to kind of show how to do this and how easy it is. But then those who attend get education on inflammatory skin diseases. We had like an amphitheater with videos, we had posters, handouts, samples, but then they actually underwent a free visit, and that was a telehealth visit. So not only do they learn about telemedicine, they actually experienced an actual visit with a dermatologist that was free. And through this, they got integrated in our medical record system that enabled us to make follow-up appointments as they walked out, as well as we had them participate in several IRB-approved surveys to generate data on the experience, but also about the disease state for which they came in the first place. And so learning and working through this, which I can throw out there, lots of challenges, lots of teachable moments as we went through this over a year or two. We crafted this model that now our hope is to fund others to emulate the same thing elsewhere in the country. Well, the first is I hope we get a lot of applications. I think for me, launching in collaboration with Pfizer a new RFP, a new grant program, a sign of success, a sign of my ability to get it out there and to be as contagious as COVID-19 with my passion and energy for this project is really going to be resulted and represented by the number of applications we get. So I really hope we get a good number of solid applications. But more importantly, those who we end up funding, I hope that they're able to accomplish what we have here in not only create a pilot, work through the ins and outs and the unique nuances of different, locations, different environments, different patient populations, but also have the kind of foresight to say, all right, this is a year project. How are we going to make this sustainable? That's a big part of the grant application is how are you going to work with your development office at your institution in order to ensure this is not a one and done, but rather a self-sustained program that continues to help patients at need. I think telemedicine, when used purposefully, can really bridge the divide. But we have to be mindful that just because whether it's us or the patients we commonly see feel comfortable or competent or have the ability to undertake telehealth visits, whether it be the bandwidth on their network or their phones or iPads, we can't assume that everyone has that same access. And so if we are going to be inclusive and welcome everyone to our practices for care, we need to be mindful how we structure both the messaging, but also how welcome we are to every patient in terms of educating them on how they can use, whether it be our in-person or telehealth practices to get the best possible care. But also, if this is of interest, please submit an application. Deadline is August 24th. I realize that's not too far away, but my hope is that this will not also be a one and done RFP, but rather we'll put a call for applications out yearly to be able to continue to support those around the country who have the same passion for extending access to care to the underserved.